Hello, everyone. My name is Christy Amobi, and I work with Xstrahl. Welcome to today's webcast. I will be the moderator for this event. Today's session will cover the application of superficial radiation therapy in small and exotic animal oncology. For almost 6 decades, specialty veterinary practices all over the world have been using radiation as an important modality to treat cancer and reduce inflammation in animals. Today, we are delighted to welcome double board certified oncology specialist Dr. Rodney Ayl from Paragon Veterinary Referrals in the United Kingdom as today's speaker. He will discuss the role of low energy X-ray radiotherapy as an important and cost-effective treatment for skin cancer, dermatological disorders, certain types of benign disease, and some palliative care in small animal medicine. Thank you for your attention, and with that, I'll hand it over to Dr. Ayl.
Hello, this is Rodney Ayl, and I'm here to provide this webinar on the application of superficial radiation therapy in small and exotic animal oncology. It's something I've been doing for a number of years. I started in the US, and now I have a unit in the UK where I'm working in Wakefield and doing this type of treatment. So for about 60 years, veterinary practices have actually had radiation therapy of some sort, using it to treat cancer and inflammation in animals. Low energy X-ray radiation is a very important and useful type of radiation. It's very cost effective, but it is limited to very superficial lesions, skin cancer, some other dermatologic disorders, certainly a lot of benign diseases, and some palliative care in both small and exotic animals. So as we go through the talk, there will be some examples of tumors that I have treated in the past that have all responded very well. So the objectives of our SRT program is to provide the option for multimodality protocols that will optimize, patient and client care under a single roof. To use the superficial radiation therapy to treat superficial and benign lesions have to be within 1.5 centimeters of the surface, as we mentioned. And it can be used as a primary treatment or an adjuvant treatment post-surgery. Also want to develop some definitive and palliative protocols for cases that do not need to get to one of the universities or practices that offer linear accelerators, which are very limited in the UK, where they would have to go certainly for much deeper and larger lesions. There are stronger orthovoltage units that can get a little deeper, but the superficial unit is exactly that, superficial. We want to develop protocols for localized treatment of certain benign and proliferative conditions that may have become resistant to any medical therapy that's been used previously. If we can minimize the need to use a systemic medical therapy for very localized superficial lesions, then that may be better for the patient. And also to make available in a logistically easily accessible radiation modality where we can treat palliatively for any superficial lesions, and again, not have to go to one of the universities for a much more complicated treatment on a linear accelerator. Histiocytomas, great responders. There's one of the benign diseases I've treated, otitis externa, where we can reduce inflammation and stop the cerumen production that these ears get, which irritate the patient. So this is the superficial unit we have from Xstrahl. It's mobile or can be stationary in one area of the room. We have it in our CT room. So we move it out of the way when they're using the CT, and when we are treating, we move it back into place. It's a dedicated 220 volt circuit, pretty easy to set up. It has the robotic arm with the X-ray unit head right on the end. There are multiple cones that attach on the head, and then there is a dial that can be used to vary the energy by moving different filters into the system. These are incorporated internally, so they don't have to be handled from external. It can actually be used intraoperative by sterilizing the cones. Obviously, the surgery would have to be done where the unit is, so not optimal in our situation. But Xstrahl actually have a specific intra-op unit that is being used for that kind of thing. For our CT shielding, it was sufficient for this unit, so we didn't have to do anything additional. So there's movement in 2 axes. It's easily fixed with a clamping system. And variable cone size, there are round cones and oblong cones up to 15 centimeters in size. There's also the potential use of lead cutouts to optimize lesion coverage and maximize normal tissue shielding. And the software is worked out so that you can put cutout calculations within the software, making it much easier to do the plans. So the control console, and of course PC, is in a radiation protected area outside the CT room. This is about the software that exists. There's the Physica software, which is basically the medical physics setup. We don't have much to do with that. There's Concerto, which is the treatment setup and unit operation system. It is essentially a record and verify system so that it does monitor what you're doing and making sure that anybody's using the unit sets up the treatments correctly. ACVIM is basically a treatment planning system where you can develop protocol templates for certain types of tumors that we often see and are repeatable. Very useful program. A couple of other things that we do: solar keratoses respond very nicely, especially when medical therapy is not working. And then mycosis fungoides, which is cutaneous T-cell lymphoma that's epitheliotrophic, so it's very, very close to the surface. And we treat quite a few cases of these. We have treated one at Paragon. So talking a bit more about the unit. So the tube head, as we said, is mounted on the end of the robotic arm, and that too can move in 2 axes. So it's quite easy to set up the system to treat in almost any direction with our pets lying on the CT table. The robotic arm is very easy to move and to adjust. As we said, the clamping system is there to keep that head in position while we are treating. Treatment time can vary from less than a minute up to maybe 5 minutes at most. So the patients are under light general anesthesia and it all works very well. The dial, as we said, is on the end of the tube. We have 5 different filters which correspond to different energies, and there's also a warm-up setting, which is essentially a block that's used for the warm-up and when we store the unit. Feline acne, great treatment. It actually reduces the inflammation and itching because it deadens nerve endings, and it will stop the lick-itch-lick cycle kind of thing, or lick-scratch-lick cycle with these, and does help quite a bit. Cutaneous hemangioma and hemangiosarcoma can be treated as well when they're in patches like this, where multiple surgeries are not going to be optimal. So just looking at some of the service features in comparison to humans, certainly has been used for decades in the humans. And many radiation therapists in the human field feel that it's a superior form of external beam radiation in its ability to minimize normal tissue exposure and to maximize the effective dose to the lesion. It actually is a more consolidated dose of radiation to superficial tumors because of the way it interacts with tissue, more so than the electron therapy, which is used by the linear accelerators. A couple of other features, certainly, that makes it very useful for us. It's quicker, easier, and cheaper as a non-invasive alternative for superficial lesions in people, especially in geriatric patients where surgery is not always a good option, and that does apply sometimes with our cases, though we still have to do a light anesthetic. It makes radiation much more available. In a good number of cases, there are a lot of these small superficial lesions that need to be treated, and being available where there are time and distance constraints for owners to get to the other big facilities. A couple of others, great mast cell tumor on the end of a lip. We've actually treated one of those in our facility, works great. Again, eosinophilic granuloma complex, that's an inflammatory lesion, also responds very well where drug therapy has not been working, or we don't want to use steroids in a diabetic patient, and we could use this. So talking about dose prescriptions, these are the intended applied doses at Dmax, which is the maximum dose where the X-rays in this case interact with tissue. So the aim with electrons is to get a superficial dose or skin dose of 90 to 95 to 100%. That is has to be manipulated to some extent because the electrons do have some skin sparing. And so to pull the dose to the surface, you have to use various kinds of bolus and so on, tissue equivalent bolus. Whereas for SRT, 100% of dose is deposited at the surface. And our rule of thumb is to calculate so you've got about a 50% of the dose at the depth of the lesion. And that maximizes dose to the surface of the lesion and minimizes dose to structures deeper than the lesion. Doses, of course, will depend on lesion size, histology, and patient characteristics. It has been shown actually that the biological effectiveness of electrons is probably 10% less than that of the superficial X-rays. So relatively speaking, we can lower the total dose that gives control with electrons when we use our superficial unit, and that does come into the calculations. So low energy photons, we've got very sharp penumbra, which is basically how far out the X-rays will radiate, because we've essentially got cones that limit the dose directly onto the tumor, and these cones touch right onto the tumor. Usually they are small lesions, which is much easier to treat. I've got a cone that goes down to 1 centimeter, which you know, you have to treat. Probably the smallest size on a linear accelerator is probably a 4x4 field. So the smaller lesions benefit here. Much less complicated to use, very easy setup. The disadvantages, obviously, limited penetration of the beam depending on what type of orthovoltage you're using. And orthovoltage does give us a higher dose to bone, which in some cases can be 2 to 4 times what goes into the tumor, because here we're dealing with photoelectric effect versus Compton effect of the interaction of the X-rays with tissue. Compton effect gives you the skin sparing effect of the linear accelerators. So here we can see the skin sparing effect at different energies. You can see up at the top there it says 300 kV, and to the left of that it shows a 3 millimeter copper filter that gives that 300 kV. And you can see that the top of that graph starts at 100%. So our percentage depth dose of 100% is at 0 depth in the water phantom. If we go all the way out to 25 megavolt electrons, which is the top graph, if you look at the hump of that graph at 100%, that's almost at 4 to 5 centimeter depth. So those things have to be taken into account when you are treating to the surface. A couple of other, one anti-inflammatory type treatment for discoid lupus, and these meibomian gland tumors, very easy to treat with this unit. We can put shields in the eyes to protect the cornea and treat that directly. Those lesions just essentially regress by programmed cell death, and so there's not a lot of damage to that eyelid. Talking about benign disease, which I mentioned is something we do treat. As with malignant growth, there is the ability of radiation therapy to inhibit cell growth and inflammation where there's release of proliferation stimulating cytokines. With arthritis, there have been experiments on rodents and dogs where they have shown that they've responded well to low anti-inflammatory doses of radiation therapy. We get reduced expression of inflammatory cytokines, increased apoptosis of the monocytes that are involved in producing those inflammatory cytokines, and so get a benefit. I used it quite a bit with some cases. I actually had my orthopedic surgeons refer to me with a linear accelerator, obviously for deeper lesions, and I treated some hip arthritis, some lumbosacral disease. We probably could treat digits with the SRT. So with SRT, I mean, with modern techniques that we use, the planning that we use, we're using smaller fields, lower doses, risk of late effects, which are the truly damaging effects to normal tissue, which we typically try to set at less than 5%, and the possibility of secondary tumors in bone, for example, are very low. And especially in the older age group that might have other comorbidities and could pass on from the comorbidities while being still under control with their tumors. So risk is definitely less, and balanced against the risks of alternative treatments like non-steroidal anti-inflammatory treatment, which can cause all sorts of gastrointestinal problems. For localized therapy, this may offer an alternative. Great for lick granulomas. As we said, it deadens nerve endings, and you can here stop the lick-itch-lick cycle. Also reducing inflammation and allowing those lesions to resolve. Very superficial mammary tumors can be treated. Some of the adenomas, obviously deeper stuff, either need surgery and or the stronger radiation therapy. So looking at some of the protocols, our standard definitive curative intent protocols is 3 gray fractions, 15 fractions on a Monday, Wednesday, Friday. Our palliative intent protocol, or hypofractionated radiation, where it's not particularly used for palliation. It's also called coarse fractionation. The standard protocol that we're using trying to establish some caseload, is 8 gray times 4, where we treat once a week. Obviously, we can have variations on these standard protocols, and as indicated by the disease and/or site, and based on time dose fractionation tables, we can work out lower doses per fraction with more fractions if we're over an area that we have to be very careful about normal tissue, much the same as planning would be done with a linear accelerator. With degenerative inflammatory diseases, much lower dose, and we might do 5 to 10 treatments. Again, it depends on what we're treating and you know, how significant the disease problem is. This is something that could be repeated 3 to 6 weeks later because it's such a low dose and very unlikely to cause any normal tissue damage. Hypertrophic and hyperproliferative lesions, slightly higher dose, also spread out over time. Also possibility of second treatments. And there's some functional diseases, even like hypothyroid cats. If there's a large invasive carcinoma that's difficult to remove surgically, we can actually treat them with this unit and get control of the hypothyroidism. With respect to palliative radiation, this is about control of symptoms. Again, with localized tumors that cannot optimally be treated by other methods. These symptoms, obviously pain, bleeding, for example, and decreased function. Radiation is commonly combined with, of course, anti-inflammatory medication and pain relief to maximize the benefit for the patient. So here's a classic case that we just actually treated this week. The red lesion was the initial melanoma that we treated in this patient with 4 fractions of 8 gray. It regressed initially and then started coming back, but you can still see it's very pink because we sort of knocked out blood flow to this tumor. Then down below you can see 2 new proliferative lesions, which are sort of satellite lesions right next to this one. That have come up over the last couple of months, literally, from the previous treatment. Now the dog is biting onto these tumors and bleeding. Otherwise, the patient is just fine, is actually on the melanoma vaccine. So no evidence of metastasis as yet. So still about local control. So what we did, this patient came in for an X-ray and we decided to do the radiation on the spot. So I did 1 fraction of 12 gray. It's a very high dose, so we got to be very careful what we treat with that. With 100 kV, which is going to give us at least a centimeter depth. So I essentially placed all these tumors into the inside of a cone, and you're actually able to manipulate the dose based on the fact that there's tumor inside the cone. You can also adjust if the tumor is outside of the cone and not just at the same level. And so I was off all other structures. We moved all the lips out of the way, and under this tumor here against the teeth, I put a shield, a lead shield, just needs to be a couple of millimeters thick, which would block any dose going further beyond the tumor. So we'll have to see what happens with this over the next week or 2. But I was able to do that planning and treat the patient all on the same day that I saw it. It would be very difficult to do that with a linear accelerator, especially if you're doing a CT scan to do planning and then computer planning, which can take sometimes even days. This was an interesting study that came out quite a while ago, about 10 years. Quite a bit of orthovoltage radiation has been done for animals in Sweden. And so they decided to ask their clients what they thought about the experience with the radiation for their pets. This is probably not a superficial unit, but it would be another orthovoltage unit. And essentially, they felt that it was a worthwhile modality, that any discomfort that their pet might have had was very manageable and acceptable relative to the benefits they gained. So that's always nice to see. So I think we have some time still to look at some patients that we've treated. We'll run through this. This is in our CT room. You can see Danny, my nurse, and myself with one of our patients and the unit to the left. So this was a soft tissue sarcoma. It was excised off the lateral aspect of the stifle. These people did not want to go to any of the universities, so they wanted us to do the post-operative radiation, definitive curative intent. So 15x3 gray, we used 50 kV. We didn't want to get too much depth penetration because there's bone right underneath that. It was a 6 centimeter cone, and we did use tissue bolus, which essentially is gauze impregnated with Vaseline to pull the dose up a little bit from the bone, so that we calculated that the bone underneath would not get too high a dose. One picture there shows a little bit of residual radiation reaction. This was, I think, 2 weeks after radiation was completed. So you can see some changes in the hair, certainly loss of hair, some hyperpigmentation, and a little erosion, which was still healing. That area was a little larger before, but we gave calendula ointment, which we found very useful, and that's resolving fine. And the pet leaves it alone; they don't lick at it. Here was another one. This was the mast cell tumor right down on the edge of the upper lip, and so we did a coarse fractionation protocol here. It was a pretty thick lesion into the lip, so we had to use 100 kV, but I was able to, again, to put a shield underneath that against the teeth, and we used a 4 cm cone to cover the area, and again some tissue bolus to pull the dose up a little bit. This was an interesting case, eyelid melanoma, lower eyelid. Hopefully you can see that there is a cutout over that eye, little square cutout. That's a 3 cm cutout, and we use then a 4 cm cone over the top of that. So that enables us to essentially block a lot of the eye and eyelids around there, and just essentially have the tumor sticking out. And we have, the program allows you to put cutout calculations in. And so my physicist just calculated the factor that I had to use in the calculations, and we were able to treat this. The other picture there does show that we put a little shield inside the eye under the mass to shield the cornea. This was a palliative attempt, intranasal adenocarcinoma in a very healthy cat. You can see the swelling over the nose that had broken through the nasal bone, was bothering the eye. The eye was starting to be almost shut completely. So the owners asked us to do some palliative. You can see how I angled the beam to try to get through the hole in the bone. And I was able to use a small cone and stay away from everything else. And again, we did put a shield in that eye. That swelling completely resolved, and we are waiting to see if anything comes back. We're using a anti-angiogenesis protocol to try to slow down recurrence. Another oral melanoma. This was more of trying to really knock this tumor back. It had regrown after surgery. Owners did not want to do a jaw excision, so they asked us to treat it. And that picture you see, I think we had done 2 or 3 of the treatments. It was very red and proliferative before and bleeding, and now you can see it's pink, and it regressed probably by then, probably 40 to 50%. Here was another adjuvant hypofractionated here for a mast cell tumor. There's a very sort of hefty dog. They did not want to amputate toes to get a wide excision, so they asked us to radiate. I used cotton wool in water just to separate the toes, try to keep the other digits and nails out of the way, and then we treated again with some bolus, but we did the short course, and we will get some benefit. Many studies have shown that with soft tissue, low-grade soft tissue sarcomas, using some radiation is better than nothing. So we don't have to do aggressive surgical protocols. We take out as much as we can, and then we're taking essentially a 50% control rate at 1 year with surgery alone, out to 75% for 2 to 3 years, even with the short course. This was a very ugly tumor. Histiocytic sarcoma growing on this dog's foot. They initially thought that it was a plasmacytoma, could not really get a diagnosis more than a round cell tumor. When it came to us, it already had a big superficial cervical node, and we were able to make a cytologic diagnosis of histiocytic sarcoma on an aspirate from that node. Now, this tumor was pretty big, was bleeding, so the owners wanted some palliative treatment there, even though we had started lomustine chemotherapy. By the time we saw the PET the second time, the node had completely gone away, which clearly must have been the lomustine. And in order to do the planning the first time, I actually had to treat a bilateral treatment, bilateral opposed, where I treated from the top and the bottom. And again, the program allows you to do a bilateral opposed, but I was treating with the full 8 gray, both top and bottom. Again, I made sure I was right over the tumor and not giving any area a double dose of radiation. By the time it came back, which is a lower picture on the left, most of the tumor on the top had died off, and it was much thinner. You can see what it looks like. So I was able to rotate the foot up and then just use 8 gray at 100 kV directly from the palmar surface. And hopefully we will continue to see regression between the radiation and the chemotherapy. Dog was much more comfortable even after the first treatment. Just thought I'd just throw in a little bit here on the exotics. This is a squamous cell carcinoma in the rema glottis. And we did a palliative course of radiation. This was in the States, 3 by 8 gray, 100 kV, and we went in through the mouth essentially. This is how we set up the bird, and we were able to, with a very small cone, get into position and treat that. I think we were able to control the tumor for about 6 months. 32-year-old, really, really nice bird. So these are tumors that are considerations. The ones in red are ones that I have treated in the past. It is quite a list. So there are a lot of things that we can do. A lot of these humans would not do. Mostly they do non-melanoma skin cancer, so basal cell and squamous cell are probably the most common that they treat in humans. But there's lots of other things that we can do, and we hope to be able to do that at Paragon. So thank you for listening. I really want to thank Xstrahl for putting on this webinar and enabling me to get out some of this information to you people out there, or something else to offer your clients for their pets when full radiation protocols are not available. We usually have been sending to Liverpool, but Liverpool is not running their radiation program right now. So essentially we've only got Southfields, Cambridge, Glasgow, and Edinburgh. So we're in the middle of all of that, and we're available to help in whatever way we can. Thank you very much, and I'll take any questions now.
Thank you, Dr. Ayl. I had a question just to kind of get the ball rolling. How well do the animals generally tolerate the treatment?
So they generally do handle it very well. The owners don't tend to see much in the way of trouble with the repeated anesthesias, even when we're doing it 3 times a week. They're very light anesthesias, very short acting, and we usually use a reversible agent. So sometimes they seem a little quiet on the day they go home, but then, you know, they're fine after that. So that they seem to handle fine. They continue eating well all the way through. As far as the treatment itself, we really don't see much in the way of side effects at all in the early phases of the treatment. As we get further along, especially in the definitive protocols where you are trying to maximize the dose to the tumor, you can start getting the cutaneous effects. And so the pets will want to lick at the area, so we usually have to do something to distract them from that, using the calendula. Sometimes they do have to wear a cone for a while. Sometimes just long sleeve t-shirts to keep things open. We don't like to wrap those things up. They tend to get infected if you do that. But we think sometimes it's more of an irritant, or even feels weird because it might be numb that they lick at it. They don't seem to be horribly painful from it. So if it gets infected, of course, it would increase the discomfort. So generally, I think they handle, you know, radiation in general very well.
Okay, thank you. You mentioned that the limited penetration is one of the disadvantages of a superficial system. Why did you install a superficial system and not a, you know, higher energy orthovoltage system such as 300 kV? And what would you recommend for clinics who do not have access to a LINAC?
So certainly as you get up to the higher energies, the orthovoltage units, you know, start from about 150 kV and probably would go up to about 450, 500. And the higher the energies available, the deeper you can go. But you still have the increased potential for, you know, the effects on normal tissues, just because it is still orthovoltage as opposed to the megavoltage. And orthovoltage, you know, is going to have the problem with any deep bone penetration. So with our small animals, it's not often very helpful to be able to get deeper areas. I looked into the orthovoltage units even when I was in the States, and in terms of where there's an overlap between what we can do on a superficial unit and what we can do on a linear accelerator, anything that's beyond relatively superficial stuff, maybe up to the 150 kV unit, those patients are going to be better served by using the linear accelerators. But as you say, where linear accelerators are not available, then certainly installing one of the orthovoltage units is much, much cheaper, easier to use for all the reasons I talked about. And, you know, it may be better than nothing. But here, where we have availability of the linear accelerators, I didn't feel I needed to go any higher. And probably the biggest thing was the cost, because here I could put it directly into a room that was already shielded. If you don't have that, you get a shielded room, and so on. That adds to the whole picture.
Sure, makes sense. Okay, next question. How do you define margins?
Yes, ongoing question. Generally, margins are determined by the surgeon who's removing the tumors, and than by the pathologist. There is a difference between a surgical margin, which the surgeons remove, and the margin that a pathologist sees after the sample has been in formalin, because it will shrink the sample by, some would say 30 to 50%. So you have to sort of take that into account. So depending on the tumor type and its grade, which will determine the extent of invasion into peripheral tissue. So, for example, mast cell tumors tend not to invade deeply through fascial planes, but they will spread out laterally as you go to higher grade tumors. So, a low grade tumor, you may only need a 5 millimeter margin, whereas with a high grade tumor, you might want to have more. With a soft tissue sarcoma, they penetrate in all different directions. And so again, you have to take that into account, also based on the staging and on a biopsy. So, it just depends on how the tumors are growing. Are they very well defined, pedunculated tumors like that adenoma, where you really don't need much of a margin? Are you trying to palliate, or actually trying to go for a definitive curative intent where you want to be sure you get the good margins? That'll determine what sort of setup we use.
Okay, thank you. Next question, there's time for a couple more. Next question, are birds and reptiles more radio resistant, and how do you work out the dose in these species?
It's a good question, and not a hell of a lot's been done. Mostly it's sort of trial and error, to be honest. And generally we use the same doses and same protocols. We tend not to do definitive ones because, we're talking about, anesthetizing a bird, 3 times a week. We probably don't do that. So a lot of the early work was done back in the States by Jane Terrell at UC Davis many years ago, and she sort of continued. She had an orthovoltage unit for many years and treated a lot of exotics. So she produced some information on that, and we generally used that and extrapolated from that. But we're mostly using palliative types of therapies for animals that are otherwise, healthy. So I've treated some rabbits with soft tissue sarcomas on their legs. Rabbits also get thymomas. We treated thymomas with a linear accelerator. They respond well when surgery is not an option. I actually treated an Indian rhino in the LA Zoo that had a squamous cell carcinoma on its horn, where we delivered 50 kV after surgery, and we pretty much cured that rhino's tumor. So, it's variable. We're mostly extrapolating from humans to some extent, but there's a lot that's been done over the years in veterinary medicine that enable us to, come up with protocols and doses that we work. It's always within safety margins, though. We'd rather undertreat and retreat rather than overtreat and get late effects that are truly damaging for the pet.
Okay, thank you. Final question, I'll just sort of combine these last two. What is your primary referral pathway, and how do you explain the treatment to pet owners?
So one of the amazing things that came out of COVID for me is the ability to do remote consults, which I think work very well in oncology. People, get a diagnosis of cancer and they absolutely do not know where to go. And so all my consults, initial consults, are remote. I will certainly speak to vets at any point in time if they have questions, but then I do a remote consult with the owner, find out what their goals and expectations are, go over what's involved logistically, in terms of the treatment and costs. And then, they decide if they want to proceed. Then the first time they come here, obviously we meet them for the first time, but we will be set up to start the treatment on that day. And because of the ease of treatment planning with this unit, I can meet the patient And literally while they're inducing, my nurses and interns that are inducing for anesthesia, I can do the treatment plan after seeing the tumor and be ready for them to treat. So it all works out pretty smoothly.
Okay, thank you so much. One final question that just came in. What sort of dose rates can you achieve? Are you doing any type of flash radiotherapy with your unit?
So, you know, the unit has a pretty good size X-ray tube with pretty good output. So the fact that I can do an 8 gray fraction or even a 12 gray fraction within, you know, 4 to 5 minutes, you know, is pretty good output. So I would say rarely do flash kind of things. I would say that single 12 gray fraction was probably the closest to anything like that. But that was for a specific purpose, and it's sort of a one-time thing. But mostly we are trying to do, you know, right by the patient, and we always are trying to make a patient-directed decision rather than disease-directed, and make sure that whatever we do, we're not going to make the treatment worse than the disease.
Okay, thank you. That concludes today's Q&A, Dr. Ayl. I would like to, on behalf of Xstrahl, thank you again for this informative presentation. Just a reminder to the attendees that you will receive a link to the recording of this event, which you can also review later on our website as well. You will receive that via email. Thank you again for your time and attention today. And with that, I will conclude this session. Thank you so much.
Thank you.